Hi, I'm Dr. Lumila Bazin, an orthopedic surgery resident at the University Hospital of Poitiers in France. Today I will explain how to perform a lumbar discectomy using an endoscopic TRANS SAP technique. For a bit of context, I am currently undertaking a fellowship in the spine unit at the Cette Center in Lyon, so the technique I will be presenting to you was taught to me by the surgeons at the Cette Center.
This video is intended for educational purposes and is aimed at residents and surgeons who wish to train in spinal endoscopy. Before going into the technical details, it is important to clearly understand what the TRANS SAP approach involves. The TRANS SAP approach, or TRANS Superior Articular Process approach, is a posterolateral endoscopic approach that consists of passing through the SAP of the underlying vertebra in order to access the spinal canal and the disc nerve root conflict. In practical terms, this technique relies on a targeted foraminoplasty of the SAP performed using burrs and terphenes. This allows widening of the foramen and the creation of a safe working corridor to the herniated disc. The main advantage of the TRANS SAP approach is that it offers a minimally invasive technique with direct endoscopic visualization. It limits soft tissue damage, reduces segmental destabilization, and promotes faster postoperative recovery. It is now an effective alternative to conventional transforaminal endoscopic techniques, particularly when the foraminal anatomy is narrow or when the standard trajectory is difficult. In this video, I will detail the indications, anatomical landmarks, and the different technical steps of lumbar endoscopic discectomy via the TRANS SAP approach as practiced and taught at the Cette Center in Lyon. The TRANS SAP technique mainly applies to foraminal and extraforaminal lumbar disc herniation, as well as posterolateral herniations, particularly when the conventional transforaminal approach is limited by unfavorable anatomy. This technique is especially useful in cases of a narrow foramen, hypertrophy of the SAP, or cranial migration of the herniation. Central stenosis of degenerative origin represents a limitation of this technique, whereas central stenosis of discogenic origin can be easily treated using a TRANS SAP technique. The patient is placed in a prone position. The surgeon stands on the side of the symptoms with the full-endoscopy unit positioned opposite them. The endoscopy tower is placed next to the full-endoscopy unit toward the patient's leg, while the full-endoscopy screen is positioned at the foot of the table. The scrub nurse stands beside the surgeon, also on the patient's leg side. It is necessary to use a 30-degree angled endoscope designed for foraminal approaches to work within the foramen. Skin landmarks are systematically marked under full-endoscopic guidance before making the incision. We begin with an AP view. An oblique line is drawn connecting the superior border of the ipsilateral pedicle to the inferior border of the contralateral pedicle. A horizontal reference line is also drawn to mark the level of the targeted disc. The fluoroscope is then switched to a lateral view. Two vertical lines are drawn. The first corresponds to the projection of the tip of the spinous processes, and the second to the projection of the transverse processes. The space between these two lines defines the theoretical safe working zone, helping to avoid being too interior and thereby reducing the risk of visceral injury. Finally, a last line is drawn on the lateral view, corresponding to the intended trajectory of the endoscope toward the SAP. The incision is marked at the intersection of these lines. Once the incision is made, the trajectory is created using a beveled Jamshidi type trocar. The bevel must be oriented as shown. This is essential to allow the instrument to anchor or bite into the SAP without slipping. The procedure always begins with a lateral fluoroscopic view to position the Jamshidi within the SAP. Once the trajectory is satisfactory, it is confirmed with an AP view. It is important to ensure that the tip of the Jamshidi reaches the medial pedicular line. When the positioning of the Jamshidi is satisfactory, a guide wire is introduced to allow removal of the trocar. The tip of the guide wire can be used to palpate and assess whether the bony tunnel remains confined within the SAP, in which case the feedback will feel hard and bony, or whether the medial cortical wall of the SAP has been breached and the wire has entered the foramen, in which case the tightal feedback will feel soft. Sequential reamers of increasing size, typically 3, are then passed to progressively create a bony tunnel through the SAP. These reamers are very aggressive and must be rotated counterclockwise while passing through soft tissues, and then clockwise once in contact with bone. The entire step is performed under strict fluoroscopic control to ensure that the instruments do not enter the spinal canal. This stage marks the beginning of the foraminotomy by preparing the working tunnel. Once the spiny tunnel has been created, the endoscope is introduced under fluoroscopic guidance to verify that the working axis has not been altered and that progression within the created corridor is appropriate. At this stage, an initial soft tissue clearance is performed using coagulation in order to expose the operative field and achieve clear visualization. The first landmark to identify is the superior border of the pedicle located here. Once identified, the working cannula can be rotated to visualize the arch created by the reamers. It is essential to carefully expose and recognize those bony landmarks as they will serve as constant orientation points throughout the procedure. After adequate cleaning, the rachis can also be identified correlating with fluoroscopic imaging. Next, it is important to identify the superior end plate of the inferior vertebra and the inferior end plate of the superior vertebra in order to assess the disc height. This can be done using coagulation to palpate the junction between the posterior wall and the disc, followed by fluoroscopic confirmation. Additional foraminectomy using a burr may be required to access the target area if the initial reaming of the SAP was insufficient. One limitation of the TRANS SAP technique is that the work is performed within a bony tunnel, meaning the burr always appears centered in the field of view. Therefore, to widen the working space, the cannula must be slightly withdrawn to allow drilling of the external and dorsal aspects of the SAP, providing more room and greater freedom of movement. After adequate drilling of the medial aspect of the SAP, the ligamentum flavum may begin to appear. If access to the spinal canal is required, for example in cases of paramedian or cranially migrated disc herniation, the ligamentum flavum can be resected with a rongeur, revealing the epidural fat. With meticulous drilling of the SAP, it is entirely possible to reach the midline using this technique. Once the bony landmarks are clearly defined and the drilling phase is complete, discectomy can begin. A disc forceps is inserted through the annular tear to initiate removal of the herniation. A ball probe can be used to retrieve fragments that are difficult to extract. In this case, the herniation is removed in a single fragment. After removal, the dural sac returns to its normal position and the traversing nerve root becomes visible. The exiting nerve root lies in this area. The ligamentum flavum, the posterior longitudinal ligament, and the now empty hernia sac can also be identified. Adequate decompression is confirmed when the nerve root is seen to pulsate. Careful hemostasis is required before completing the procedure. Thank you so much for watching this video tutorial. Please feel free to leave any questions in the comments. I'll be happy to answer them. I would also like to extend my sincere thanks to Dr. Dastorg, Dr. Jakowski, and Dr. Castel for their kindness and outstanding teaching.